Ευχαριστώ. Εξαιρετική εισήγηση και όπως πρέπει να αντιμετωπίζουμε πλέον αυτά τα ερωτήματα ή αν θέλουμε να μιλήσουμε και με άλλη ορολογία, είναι μια ολιστική, έτσι, ωραία λέξη, μια ολιστική. Εμάς τους δυτικούς γιατρούς μας κατηγορούν ότι κοιτάμε μόνο ένα πράγμα. Στην ουσία κοιτάμε με λάθος τρόπο, εγώ πιστεύω, και είναι μια προσέγγιση αυτό που λέμε, κοιτάτε περισσότερα από αυτά που θέλετε να δείτε. Λοιπόν, ας προχωρήσουμε, είμαστε ακριβώς στην ώρα μας, πάρα πολύ ευχάριστο, να προχωρήσουμε στον δεύτερο μιλητή. Dr. Davies, are you online?
I think so. Can you hear me?
Hello, Win.
Hello, Vasilis. It's good to see you after so long. You look very well.
You look too. I still remember you.
Likewise, I still remember you.
Okay, I'm very glad.
But you are hard to forget, Vasilis.
I'm very glad to see my old mentor, I would say, Dr. Win Davies, who taught me 30 years ago the secrets of electrophysiology and cardiology, and I owe to him a lot. And he's one of the pioneers of atrial of ablation and atrial fibrillation ablation as well. I think when he's in the best place in the world, somewhere near us, but how you call this island? Paradise or what?
Yes,
Sardinia.
Sardinia, yes.
We're in Sardinia. So
and the way the things are changing in the UK, I might stay longer here.
I'm glad you are in Sardinia still and not in London. So Win Davies is one of the most experts in the world to tell us. We heard about atrial fibrillation ablation, and this is number one procedure nowadays. But also there are some big trials, and there are still disputes if the trials show that ablation is good, that you have to take medical treatment, and so on. And always there's some controversies. And Win Davies is going to give us a hint. What do the recent trials really tell us about the atrial fibrillation ablation? Win.
Thank you, Vas, and thank you very much for asking me. I'm sorry that due to circumstances that we all know, I can't be there in person. I was looking forward to visiting Thessaloniki again, but maybe another day. I'm going to review principally two major studies from the last couple of years. I'm a cardiologist in London, have been for a long time, as Vas has just said. And because Cabana is a study that I'm going to be partly reviewing, it's important you know that I'm a co-author of Cabana. I was the primary or principal investigator for the UK for Cabana, and I chaired the New Technologies Committee for Cabana, which basically decided how new technologies could be accepted within an ongoing trial. So as I said, I'm going to concentrate principally on two. I've included East because it's only very recently been published, and I had expected to see rather more experience with atrial fibrillation ablation. Perhaps that was naive. It started in 2011, 9 years ago, but I'll mention it towards the end. But I'm going to concentrate on the first two. Castle AF, the first author, Nasir Marouche. It was a multi-center, open-label, randomized controlled trial. And the question was really looking at was the fact that we know that mortality in heart failure patients is increased if those patients have atrial fibrillation as well as the heart failure. And therefore the question was, could catheter ablation of this atrial fibrillation reduce the mortality rate in this sick, high-risk population? So 363 patients with heart failure and symptomatic paroxysmal or persistent AF. So for reasons that I'm still not clear of, asymptomatic AF was excluded. All of them had left ventricular ejection fractions that were significantly impaired below 35%. They all had a biotronic ICD in place and had either NYHA class 2, 3, or 4 heart failure. They had been identified as being either unresponsive to antiarrhythmic drugs or had unacceptable side effects or refused to take them. And they were randomly allocated then to catheter ablation, 179 of them, antiarrhythmic drug therapy, 184. The primary endpoint was a composite of death from any cause or admission to hospital for worsening heart failure. There was a 5-week run-in period so that heart failure treatment could be optimized before the patient entered the study properly. In the catheter ablation arm, the aim was to achieve pulmonary vein isolation and restore sinus rhythm. All operators had performed more than 50 procedures, and I'll come back to that figure shortly because it doesn't sound like a lot. And if there was evidence of clot in the left atrial appendage or elsewhere, but principally in the LAA, the procedure was delayed until the clot dissolved. All patients post-ablation were put on warfarin for 6 months. For the medical arm, the treatment was according to the guidelines of the time. And for the atrial fibrillation management, it was the ACC, AHA, and ESC guidelines of 2006. And for heart failure, it was according to the guidelines of the ACC, AHA 2005. The figure of 50 comes from the expert consensus statement of 2017, where the writing group members are supportive of the requirement that trainees perform at least 50 AF ablation procedures. So that's where the figure 50 came from. But it represents a minimum training requirement rather than an indication of expertise, I would say. Follow-up, they all had the Biotronic home monitoring system for AF, obviously interrogation from the device, with formal follow-up visits at 3, 6, 12, 24, 3 years, 4 years, and 5 years from baseline. And at every follow-up, there was an ICD check, an adverse events check, an echo, and a 6-minute walk test. So, screened just over 3,000 patients, of whom almost 2,000, well, over 2,600 were excluded, so that only just under 400 were enrolled and then randomized. One had a violation of inclusion criteria, so we're left with 200 assigned to ablation, 197 assigned to medical therapy. And for a variety of reasons, some of these were excluded during the run-in period for ablation and also for the medical management. So we end up with 179 remained after baseline evaluation in the ablation arm and 184 in the medical management arm. 151 of the AF ablation patients, the ablation arm, received the assigned intervention. 23 were lost to follow-up from the primary endpoint. But according to the intention to treat, 179 patients were included in the primary analysis, even though some did not receive the ablation. Likewise, in the medical arm, 18 did not receive the assigned intervention for a variety of reasons, and 10 were lost to follow-up for the primary endpoint. But the original 184 were what the analysis was based on. The exclusion criteria are numerous. So any previous ablation for AF, contraindication to anticoagulation, left atrial diameter of more than 6 centimeters, acute coronary issues, another planned cardiovascular intervention listed for heart transplant, etc., etc. So there were numerous exclusion criteria. So patients with the Castle AF were screened from heart failure clinics and EP clinics, so that these patients did not come directly straight only from heart failure clinics or from arrhythmia clinics. And those other indications and inclusion criteria I've mentioned already, so I won't repeat those. In some patients, all inclusion criteria were met, but they violated at least one exclusion criterion. So, for example, 7.4% of the 768 patients that were okay to enter the study, 7.4% had already been listed for heart transplant. 3.1%, for example, had previous AF ablation. 1.7% had a left atrium that was too big, etc. According to the country, this was principally a European study, and obviously with Biotronic ICD, it's no surprise that Germany was where most of the patients came from, followed by Russia, then Australia, Hungary, the Netherlands, and a smattering from elsewhere. This is a a slide showing the distribution of patients per site. And we saw a similar potential issue with Cabana in that if you look at these data, you'll realize that over half of the patients came from 6 sites. So it's difficult because you have enthusiastic sites in these multi-center, multinational studies that will inevitably recruit more patients, but it is important to remember that this perhaps just reflects the practice from relatively few sites as opposed to across the world. This just shows that the clinical characteristics of the patients randomized to ablation versus medical therapy were essentially the same. The type of atrial fibrillation, I think, is quite important when you're looking at patients with heart failure. We tend immediately to think of patients with persistent atrial fibrillation and perhaps an element of tachycardiomyopathy, but 30% in the ablation arm and 35% in the medical therapy arm actually had paroxysmal AF. So 2/3 of the patients only had persistent or long-standing persistent AF. Long-standing persistent meant over 1 year. The ejection fraction, as I said, was under 35%, median the same. So essentially, these were well-matched populations for comparison. Of the ablation group, 179 randomized, as I've said before, 151 received the ablation, and a mean of 1.3 plus or minus 0.5 procedures per patient. The goal of pulmonary vein isolation was completed in almost all, but not quite, at 98.7%. And additional lesions, various, applied in over half of that patient group. 28 or 15%, almost 16%, crossed over to medical treatment. And I'll come back to this point. I think this is one of the issues I think it's making comparison of medical therapy versus ablation rather pointless and redundant, but I'll come back to that. And in the medical group, almost 10% crossed over to ablation, and a rhythm control strategy was applied in approximately 30% of patients, which means that 60 to 70%, the emphasis was on rate control. So the results, if one looks at the primary composite, which, if you remember, death of any cause and hospitalization for worsening heart failure, in the ablation arm, that was seen in 28.5%, compared with 44.6% in the antiarrhythmic drug therapy, a highly significant outcome, p-value 0.007. Likewise, the individual components of that death, admission with worsening heart failure, and any cardiovascular death, there was a significant difference in favor of ablation for all of those categories. And here you'll see the chart showing to the left of that dotted line that ablation was better, medical therapy was better on the right side. Interestingly, and perhaps counterintuitively, the group in which medical therapy was clearly better were those patients with even more significant impairment of left ventricular function at less than 25%. Looking into that, it's perhaps an indication of other processes going on rather than the role of atrial fibrillation in the deterioration. We look at these data in different formats. So probability of survival, so the higher line of the graph indicates a better outcome. So for worsening heart failure, death or hospitalization, the composite primary endpoint, very much in favor of ablation, as the figures previously showed. Likewise for death from any cause and hospitalization for worsening heart failure. At 60 months of the ablation group, that's 5 years, 63% were in sinus rhythm, whereas 22% of the medical management group were in sinus rhythm. In terms of left ventricular function, there was a median increase of just under 10%, ranging from 2.2 to almost 20% in the ablation group, but virtually no change in the medical group overall, an increase of 0.2%. In terms of crossover, in this study, more patients in the ablation group crossed over than did from the medical group, but the results were similar whether analyzed by intention to treat or as eventually treated. unlike Cabana, as I'll come on to shortly. And here is the Cabana study published in JAMA 2019. And the objective here was pure and simple, to determine whether catheter ablation is more effective than conventional medical management for improving outcomes in AF. It was investigator-initiated, that's Doug Packer, open-label, multi-center randomized trial, performed from 126 centers in 10 countries. In this case, all operators have performed at least 100 AF ablation procedures. 2,204 patients, all again symptomatic with AF, were randomized almost equally to ablation and to antiarrhythmic therapy. The patients were either aged over 65 or were aged under 65, but with one or more risk factors for stroke, according to the CHADS-VASc system. The enrollment started in November 2009 and finished in April 2016. And the patients were followed up until December 2017 at the end of that year. There were 13 pre-specified endpoints. The primary endpoint in the study was composite, again, of death, disabling stroke, serious bleeding, or cardiac arrest. 3 of these were included in the original JAMA paper: all-cause mortality, total mortality, or cardiovascular hospitalization and AF recurrence. The others were included in a supplementary publication. So, 2,204 patients randomized, median age fairly typical for an AF population at 68, majority male, 37.2% were women. Again, majority persistent atrial fibrillation, but closer to being 50-50, is 57% persistent, 43% paroxysmal. Just under 90% of patients completed the trial. Of the 1,108 patients randomized to ablation, 90.8% received that, but almost half were receiving drug treatment at some point during the study, or did receive it, and at the end of the study, the last follow-up visit, over a quarter were taking drug treatment as well as having had the ablation. In the case of those randomized to drug treatment, almost 100% received it, 99.6%. But almost 30%, 27.5%, crossed over to undergo catheter ablation. The results therefore reflect this. On an intention to treat analysis, that just repeats the figures that I've told you before. And this is again to show that the populations were well matched. There was no significant difference in age, gender, ethnicity, etc. Likewise, no other significant difference in history of coronary disease, hypertension, diabetes, etc. Likewise, the ablation history in terms of time to onset, duration of AF, persistent versus paroxysmal versus long-standing persistent, they're well-matched groups of patients. But by intention to treat analysis, initially apparently disappointing, there was really no significant difference in the primary endpoints of components, the composite primary endpoint or the individual components. P-values, as you can see on the far right, whether this is a direct comparison of events or the Kaplan-Meier 4-year event rate, there is no significant difference. There is a significant difference on an intention, and it's highly significant, with death or cardiovascular hospitalization in favor of ablation. So that reduced death or cardiovascular hospitalization significantly compared with medical therapy. And these graphs show again that this time they're the other way around, so that the event rate climbs as opposed to the success rate on the left. Drug therapy and catheter ablation, no difference at the end of 5 years that's significant. All-cause mortality or cardiovascular hospitalization, again, slightly in favor of catheter ablation, but no significant difference at all. Similar graph here from the one I showed in Castle AF, where to the left of the line are the patients that the outcomes favor catheter ablation. So in red are the ones where there's really very little crossover to favor drug therapy. And it's worth, I think this is quite an important slide because it helps with therapy selection, patient selection for kind of AF therapy that you have available. So aged under 65, there's clearly a significant advantage to catheter ablation in that group, in that there's no crossover towards favors drug therapy. Likewise, the male gender, for some reason, interestingly, the minority ethnic groups do very well with catheter ablation as opposed to the Caucasians, the whites. That's mysterious to my mind, but it's identifiable there. Coming back to age, anybody over 75 doesn't really seem to benefit from catheter ablation, perhaps more effort made on medical therapy for that group. Cardiac failure, benefit, along with Castle AF, benefit from catheter ablation. If sleep apnea is present, then catheter ablation should be offered. And if the patient is not obese, then there's much more benefit from catheter ablation than otherwise. If, however, one looks at the effect of what treatment was actually given, bearing in mind the crossovers, it's not an intention to treat analysis, it's according to treatment received. You'll see that catheter ablation begins to separate itself from drug therapy. As time goes by, at 6 months, it's not quite statistically significant. By the time 12 months is reached, then there is a significant difference of the primary endpoint, that composite endpoint, in favor of catheter ablation. And after the blanking period, by an intention to treat analysis, recurrent atrial fibrillation is far less often seen in catheter ablation patients than drug therapy patients. That's no surprise. We've seen that graph from multiple studies over many years. So if we compare the studies themselves, they were worldwide. There were far more centers enrolling patients in Cabana, and Asia was involved. Otherwise, the distribution was the same. Large number of patients screened. We don't have that figure for Cabana, at least I don't, I could find. Significantly more patients randomized for Cabana. Crossover, interestingly, opposite directions for the two studies, but it's an issue. It's at least 10% and up to 44.5%, 6% in Cabana. Follow up a bit longer with Cabana, etc. And the distribution of AF slightly more persistent as a percentage in the Castle AF group, because that's what you'd expect with a population presenting with heart failure. I'm going to mention EAST very briefly. I had expected this to contribute information about the role of AF ablation versus medical therapy. It's basically a randomization of treatment for early atrial fibrillation, i.e. within 12 months from diagnosis, with increased risk factors, either aged over 75, a previous CVI or TIA, or two of the following risk factors, aged over 65, female gender, heart failure, hypertension, diabetes, severe coronary heart disease, renal failure, and left ventricular hypertrophy. Almost 3,000 patients from 135 sites in 11 European countries. It's an event-driven trial, and they were randomized to early rhythm control, 1,395, or usual care. Usual care is a little bit too vague for my liking, but usual care, whatever that is, for me in 2011, usual care was rhythm control. So it's up for debate. But the patients were randomized between 2011 and 2016, and the enrollment occurred a median of 36 days, so really quite early on after the diagnosis of atrial fibrillation. Again, primary outcome, composite of death from cardiovascular causes, stroke, or hospitalization with worsening heart failure or acute coronary syndromes. Second primary outcome was number of nights spent in hospital per year. There was a primary safety outcome, composite of death, stroke, or serious adverse events related to rhythm control therapy, and secondary outcome, including symptoms and LVH. The reason I'm not going to say much more about EAST is in this slide. The rhythm control arm is on the left as you look at it. 2 years after randomization, less than 20% of patients, the pale blue bar at the bottom, less than 20% of patients had received AF ablation. I was a bit surprised when I saw this. I had thought it would add more information to when and how to offer AF ablation, but it really doesn't do that. There aren't enough patients here. So I've included it because it's recent, it's a big study, but with respect to information about AF ablation, I'm afraid it hasn't advanced our knowledge. So what have they taught us? Fundamentally, at the moment, I think that long-term studies that compare AF ablation with medical therapy for AF should not be started anymore. They cannot be completed on an intention to treat basis. We know already that if you want to reduce AF burden in a patient, ablation is going to do better than antiarrhythmic drug therapy, especially for paroxysmal AF. However, in patients with heart failure and atrial fibrillation, one should consider ablation very seriously, as there clearly is a potential for significant benefit in many of those patients. Treating obesity is important. Sanders in Australia has shown us this already by forcing half his patients to diet properly. Their AF burden reduced significantly. And whatever means of treatment you're using for atrial fibrillation, if you can get patients to lose weight, they will do better. At least in Cabana, racial minorities responded better to ablation, Caucasians. I don't know why that is. Medical therapy, however, should be considered seriously in patients with very severe LV dysfunction. That's not to say that one shouldn't rule out ablation, but in patients over 75 years of age, perhaps it should be considered very much as an alternative to ablation. Ultimately, you expect sinus rhythm in no more than 50 to 60% of patients after 5 years. And to say that patients cross over from AF ablation to medical therapy, I think is naive. I don't think they're competitors. I think they're colleagues, AF ablation and medical therapy and the management of this complex condition. So I think we should use them in that complementary way. Thank you very much for your attention.
Thank you very much, Dr. Davies, for this excellent presentation. Is there any question from the audience?
Yeah, just want to make a comment, sorry, Philippos. At the end of the day, after so many millions were spent and so many patients were randomized over a decade, we come and say the same thing. And I think this is the most important. These two treatments are not competitors. They come and help each other. And then you have to decide the kind of atrial fibrillation ablation you're treating. I think that's...
I completely agree, Vas. That's really the conclusion I try to make at the end. I think it's naive. First of all, the studies have demonstrated that you can't make an intention to treat comparison of these two treatments. It's not ethical to prevent patients who are suffering on medical therapy from receiving an ablation. And it's not ethical to prevent patients who've had an ablation that need medical therapy to complement the effects of the ablation. So, as you just said, they're not competitors. They're sort of they're colleagues.
Professor Trυποσκιάδης want to ask a question to the microphone.
I enjoyed very much your presentation. I have a question for you. You mentioned that heart failure is an indication for patients with atrial fibrillation, and they should undergo ablation. Does this apply to patients with heart failure with preserved ejection fraction? And if not, why these patients were not included in the studies?
Yeah, that's a good question. And because they haven't been included in the studies, the answer to that question is we honestly don't know, because that group of patients hasn't been studied in any number. I think the logic behind the CASTLE-AF recruitment policy was the possibility that there was at least an element of tachycardiomyopathy in those patients. And we know that this is an underdiagnosed condition. People too often assume, in my experience anyway, clinically, that the atrial fibrillation is a component, it's a part of the disease process that's causing the quotes cardiomyopathy. And not enough people think that the atrial fibrillation might be contributing, if not be the whole cause. of the cardiomyopathy. And so those patients, by definition, will all have impairment of left ventricular function, then that's where we see it improved. But the heart failure with normal ejection fraction, I don't think we know enough about the role of AF ablation in those patients.
Yeah.
Okay, thank you.
Thank you very much. Any other questions?
Professor, yes, Vasilis.
Yes.
Dr. Davies, do you think that the EAST trial will be lead to more ablation procedures and earlier, and what are the consequences of that?
I'm not sure that EAST was meant to address that. I think I read it and I looked at it and I thought, how does this change what I think? And I honestly didn't really find something that, but looking back at when it started, it really followed the disappointment of a firm, which allowed patients, after sinus rhythm, at the discretion of their cardiologist, after sinus rhythm was restored, it allowed for anticoagulation to be discontinued. And I think it sought to address that by including anticoagulation long-term in the medical treatment arm. But I was disappointed. I had hoped to see at least enough patients receiving AF ablation in EAST to have some kind of subgroup analysis, but I don't think EAST will help us with the AF ablation question.
Thank you.
Any other questions? Okay. Thank you very much, Wayne. Very nice.
Pleasure, Vasilios, and thank you again for asking me. I hope we can meet in person. It's been far too long.
Yes, sometime. Yeah.
Exactly.
Okay. Thank you very much. Enjoy your stay there. Okay.
Take care.
Thank you. Bye-bye.